All right, welcome to the first ever DHC review lecture by GUMS. So hopefully this will be high yield DHC topics that will come up in the exam. Sasha, Michael's going to be helping me edit the video, so just bear with me if I say next slide all the time. Okay, next contents. So this is high yield topics to cover, in my opinion. The BMB term is quite short. They didn't cram as much DHC into it, which is good. Gives you sort of a limited amount of stuff to study. Most people don't study well for DHC and BMB, which, I can't blame you guys. It's a tough semester, so I'm guessing PICO is probably the most important one to focus on, and the Q&As and biopsychosocial factors, but we'll cover that in detail. So next slide is disclaimer. Again, I can't possibly cover everything that's on the exam, and I can actually be wrong about some things. So yeah, if you see anything that needs improving or is completely wrong, just let us know. Next is general advice. So basically there is logic to the madness. A lot of DHC teaching is done quite poorly, and that's a fact. But DHC Q&As actually provide a lot of the answers to the questions on the exam. So that's where the logic comes from. As Wadia said recently, there is a level of rote learning that's expected in medicine, and it is definitely the case with DHC. If I had to break down the exam content for you, 90% of the answers come from the formative Q&As. Probably about 9% come from stats lectures that they'd like to focus on. So for instance, this year would have been PICO. And 1% are just read questions that are just bizarre questions no one knows the answer to. So rest assured, there's only 1% of those. Everything else is actually provided. In general, SAQs focus on non-stats content, so that's your sort of public health, Indigenous health questions. And MCQs are more stats heavy, so really testing your understanding of the stats that they've taught you. There's a lot of risk factor questions, like what are the risk factors for diabetes, and prevention questions. So remember, primary, secondary, tertiary, prevent, screen, and treat. So something that you might expect in the MCQ would be calculating, let's say, sensitivity. And they'll give you actually a 2x2 table. And so DHC is tricky because it builds on previous year's content. So knowing first year stuff is important because a lot of the PICOs and the critical appraisals build on your understanding of stats and study design. So the advantage, I guess, of having the Q&As, as much as it is annoying because it is basically self-taught, is that you have a limited amount of information to study. So if you just look at Q&As and nothing else, that's actually a pretty good strategy. Plus you understand the stats, that's actually a really good strategy to tackle the exam. There is nothing else that you need to do. Okay, next slide is content you should know by year 2. Again, this is just more for me to know what to teach in the first year review lecture, which I'll be doing in the next month. Hopefully I can do it before the BMB exam so you can use that as a refresher. So all of these are important for year 2, and knowing your critical appraisals and PICOs, and it will come up in the MCQs. Okay, next is exam favorites. So again, this is what I remember from second year. So I'm a third year, so I remember this from last year. So in 2019, there was a bit of a weirdly worded question on strength-based approaches in Indigenous health. And I think a lot of us put down strength, taking it quite literally, put down OTs, physios, stuff like that. But they wanted strength-based as in putting a positive spin on what Indigenous people can do in health. So that question got complained about quite a lot. Yeah, there'll be at least one question in the biopsychosocial grid, and we'll talk about it a bit later. I think there's going to be a PICO question and SAQs. PICOs is what's going to be tested on the BMB exam. So get ready. Yeah, there'll be at least one MCQ in health economics, but maybe two at most. I remember one weird PBS question on SAQs, and it was nothing that was covered in formative Q&As. And that question actually, I think, expected you to read PBL material. That wasn't part of the LOs. So again, I just wrote down what I knew about PBS and hope for the best, but that's a red question. Don't worry about critical appraisals for this semester. That will be assessed in the next semester, so at the end of the year. The Parkinson's question and the Q&As, I think that came up for us in the formative exam. I'm not sure it will come up in the actual exam for you. I think there were a couple of hearing loss MCQs, and I think, in the SAQ we had an allied health professional question. So a person with disease X, what kind of health professionals can help them in treatment? And I think I put down like physio, again, OT. I think it was post-stroke. All right. So this is just basically an idea for you to have an idea of what's going to may or may not come up or came up in the last year's exam. The next slide is, so ROC curve, or an example of a red question. I put this only because I've seen this question twice, once at the end of first year and second time at the end of second year. It might not come up this year for you, but it seems like they're recycling questions. So it is a red question, like no one kind of knew what they were talking about. Basically, there'll be a question about, I think ROC will be in the question stem, and then the MCQ will be what will be on the x-axis. And you just need to know that it's true positive on the y-axis and false positive on the x-axis, and that's about it. I'll put the curve in just to show you where it comes from. Again, just an example of a super red question that, I don't think anyone is expecting to know, really. All right, next is study tips. So again, can't emphasize enough how important it is to know stats. And when I say know stats, you don't need to have a stats background. I certainly don't. But you just need to understand the logic behind them and be able to apply the statistical concepts that DHC teaches. And I know that I teach them well, so this is why I'm here. So a couple of strategies. I actually learned a lot of the formative Q&As, and I did that, I think, a week prior to the exam, so in the study week, and kind of put them all in the Yankee decks and just read them every day and committed them to memory. A few friends of mine actually don't do that, and they prefer to do past exam questions and just read the answers and sort of work out what is expected as a good answer. So basically, do whatever works for you. I'm not telling you that one strategy is better than the other. But again, a level of rote learning is expected, and I know a lot of people don't do that, but then there's a lot of complaining that DHC is hard. Well, it is hard, and it's because a level of rote learning is expected. So just a few, tips of how to tackle DHC. So I found that really useful is creating a booklet of all the DHC LOs. And just a little quick note on the LOs, there's a significant overlap between Q&A answers and LOs. I would say 85 to 90% of the LOs are covered in the formative Q&As. Everything that is not covered by the Q&As, I would say, is fairly low yield. So focus on the Q&As again and the stats. If you find that useful, is to create a booklet of all the LOs, keep track of them, or use super notes. There are plenty of super notes out there. Again, if that helps you, flashcards are great, especially for stats concepts that I just find, like for me, I sometimes find it easier to remember something off by heart before I can actually fully understand it. So memorizing definitions before I fully understand them. Again, I know it might sound backward, For most people, it's the other way around. So do whatever works for you. Study group's actually great. So there's bound to be a bunch of people in med who have had social sciences background, psychology background, or research background, or some sort of statistical background that would be able to explain complex topics in a far simpler manner than you think. I definitely know that because of my research background, some things I'm able to explain better to a friend of mine who's got no stats background. Just really dumbing it down. This is sort of the high yield stuff that you need to focus on. And there are a bunch of online resources that are good, and I definitely use a lot of them. And there'll be a slide at the end sort of directing you to those. All right, next slide is biopsychosocial factors. I'll keep it fairly brief. So essentially there'll be a grid: biological, psychological, social, and there'll be disease that's come up in the Q&A. So something like chronic disease, epilepsy, psychosis, or dementia. And by the way, if I'm covering something that you haven't done or is completely out of whack with your lows, let us know, because then we can sort of reshuffle them, because there is a set number and amount and content of lows that DHC teaches every year. And if they're vastly different from what I'm teaching you now, then yeah, definitely let us know and I'll try to adjust. So yeah, essentially just go by the answers. But for biological things that you might want to sort of talk about is disease factors, such as pain or effect on memory if it's stroke. Psychological, you want to talk about coping, effect on personality, perhaps depression or anxiety. A lot of older people who have had strokes or anything happen to their health do get quite depressed. And social, I think if you mention things like housing, money, education, relationships, or anything cultural, you're kind of hitting all the key social bits. But again, go by the formative Q&A answers. And just to sort of give you a little bit of hope, this is super useful for mental health rotation in third year. It's called the biopsychosocial formulation. So yeah, it's not just wasted on DHC. Okay, next slide is the dreaded PICO. All right, so a lot of people hate these questions. I mean, I can sort of understand why. No one goes to lectures, is taught poorly. I think the most important thing to know about PICOs is that they can be incomplete. And if they're incomplete, it doesn't necessarily mean that it's wrong. A lot of content is implied. So if you get just the population and just the outcome, it actually might be the right PICO, especially for qualitative questions. So I had never come across PICOs before in my prior research career. And yeah, I'm not really sure why. I guess I never sort of studied social sciences, but it makes sense. It makes sense why they're teaching you this, but it's hard because those of you who haven't done research, it can feel a bit formulated and unnecessary. It will come up in SAQs. Last year we had a 5-mark question on PICOs and a search strategy that you would put in to search for that particular PICO. So I'll talk about it in the next slide. But let's just talk about the variations of PICOs. So PICO, as you know, is population, intervention, control, and outcome. So for instance, if you're looking at a cross-sectional study, and when I think about cross-sectional studies, I usually think of something that is like a snapshot in time. So you're surveying a big population, you're not following them longitudinally, you're not following them back to their medical records 10 years ago. It's just literally, let's just give a questionnaire to people and they will answer it, and then we'll know what they're thinking at that point in time. So let's say we give an anxiety questionnaire to medical students. So P population is the survey population, so the medical students. Intervention is the questionnaire that we're giving them. And control, like oftentimes control doesn't exist for some studies. So control is like the gold standard. Good studies should have controls. A lot of studies are not good and don't have controls. So for instance, if we're giving a questionnaire to medical students about anxiety and not using dental students as a control, then there is no control. The outcome of the study is obviously anxiety ratings. All right, so with That's cross-sectional done. Case control, remember case control looks at rare diseases, so outcome is the disease, and it looks back in time through medical records to find exposure or something that may have caused that rare disease. So let's say people with rare blood cancers, we're studying by medical record review. So our population is people with rare disease, blood cancers. Intervention is our exposure that we're looking for. We don't know what it is. Let's say being bitten by a mosquito. And control, case control, like control is in the word. So usually it'll be people without that rare disease that we're looking and tracking over time, and they'll be sort of age matched or similar in other ways to the population that we're studying. And the outcome is implied. It's the rare disease. So that's what I think trips people up, is that, oh, well, there is no outcome. Well, it is. The outcome is the disease itself. All right. With cohort, it's essentially, cohort is like the preliminary study before the RCT, the gold standard. So cohort is, you have a population of people that you're following over time, and you can follow them for a couple of weeks to see if the intervention has worked, or you can follow them for years and years and years. So again, you start with the exposure. So case control and cohort studies are flipped. Cohort, you start with the exposure and then you wait for the outcome to develop. So we can look at, say, a lot of survival studies are cohort studies. So let's say you're testing the effect of chemotherapy on this rare cancer that is usually not treatable by anything. And all you're trying to do is prolong survival. So your population is people with this rare cancer. Cancer in this case is the exposure. Intervention is the, population, people with rare cancer. Intervention is the chemotherapy that you're giving them. Control, you may or may not have a control of people who have a different type of cancer. And the outcome is the time to death. So if it is longer, then the outcome is better. I hope that makes sense. So let's say a cohort of patients who are visually impaired. So let's not talk about survival. And so people with visual impairment, exposure is giving them injection in the eye. So for instance, they have wet macular degeneration. Controls could be people with dry macular degeneration that can't get injections, or someone else. And the outcome is improvement in visual acuity. RCTs are basically the gold standard, are probably the easiest ones. So RCTs, you have people who are enrolled in the study who meet certain inclusion and exclusion criteria. So the population is the people who are getting the drug and they meet the criteria. Intervention is the drug. The control is the people who get basically the placebo or the standard treatment, depending on the design. And the outcome is the desired outcome of that intervention. Or are they lowering blood pressure? Are they increasing concentration with drugs like modafinil? So RCTs are probably the easiest ones to fit to PICO. And the hardest one would probably be qualitative, because it doesn't really fit PICO. So let's say we're looking at why med students don't attend DHC lectures. Your population of interest is med students. And you don't really, there is no intervention or control in the qualitative studies. So your outcome is why they don't attend DHC lectures, and you would answer that with focus groups or something. Probably one more study that hasn't been talked about in study design but it's tested in critical appraisals, is the diagnostic accuracy study. So let's say you're testing and you test to diagnose bowel cancer, but it's not the fecal occult blood test, it's something else. And the gold standard is colonoscopy. So your population is people with colon cancer. Your intervention is the new test that you're testing. Your control is the gold standard, and your outcome is detection of disease and calculating of sensitivity and specificity and other outcomes from that diagnostic test. So All right, next slide is search strings. Again, I'm only putting it in because it came up in the past exam question. And it makes sense if you're doing, I'm sure some of you will be doing research projects as part of first year or second year expression of interest that's been sent out early in the year. And a lot of us will have to write literature reviews for those particular projects. So there is kind of a point to, there's a point to teaching this. I definitely didn't know about this, and I wish I'd learned this before I started my lit review. So if you have something in particular that you want to search without losing the content, so like a phrase, you put it in quotation marks, so that's pretty obvious. Truncation, so again, you put an asterisk at the end if you want to look at teenagers, teens, and that sort of stuff. Connections, again, and or not. So if you want to look at, for instance, if you don't want to use quotation marks for quality of life, you can put quality and then and life in the title, and it'll come up with every study that comes up with quality and life in the title, but not together in one phrase. Use brackets, synonyms, keywords. Basically, yeah, it's pretty self-explanatory. I think what's important is to know the databases. So you want to look at Cochrane, you want to look at Medline, Embase. Embase and Medline are quite different, and they use different subject headings. And so it's good to use those two to sort of cross-reference each other because they're sourced from different pools of articles. So essentially with the exam question, you were given, I think, a description of a study, you had to figure out a PICO, and then you had to figure out how you would search for it. So I think I just put and for everything. I said I would put this and this and this in the search string, which I'm sure was a little bit dumb. So make sure you want to mention Medline and Embase and maybe subject headings. Okay, next slide is subject headings. Just wanted to say, again, I didn't know this when I started research, and my God, it would have saved me so much time. Basically, for instance, PubMed, which uses mesh headings, they've already pre-categorized a lot of the content into headings. So, for instance, if you want to look at hypertension and or toxicity, or like, for instance, they're talking about asthma drug therapy. So if you want to look at asthma, you can go into that subheading and look for every single article that is grouped by asthma as a research question. And I think ideally for a good research strategy, you need to use both. You need to use subheadings. So just looking at the whole content of that, the PubMed version of what they think comes into the asthma subheading, and then also searching it individually with separate words in those databases that I mentioned. So anyway, that's probably something that's important to put in the exam if you're writing about this, and I've left it here for you to explore, but definitely take more time and have a look at it in your own time if you're interested. All right, next slide is health economics questions. Again, I don't want to go into too much detail because it'll be 1 or 2 MCQs, maybe 1 or 2 this semester, and then 1 or 2 at the end of the year, and probably 1 at most. I find I struggle with the definitions, so I find the table works a little bit better for me. So if I see qualies in the STEM, I'm thinking cost utility straight away. If I'm thinking net gain or loss in dollars, that the question is considering sort of saving money on something, I'm thinking cost benefit. If it's a ratio and it says per life year gained, think cost effectiveness. And if it's just dollars, then look at cost minimization. I'm sure there are better ways of explaining it, but because it's not assessed that much, I would just leave it at that table. All right, next slide is how to tackle critical appraisals, and I'm sure this is what you've been waiting for. Again, can't emphasize enough that this is not something that's going to be tested in this coming exam for BMB, so don't worry. There will be a section of the exam next year, at the end of this year, for second year for you, an SAQ section dedicated just to stats and critical appraisals. So I think last year we got a sort of half a page of text describing a study, and then the question was, what is the study design at question, and sort of critically appraise it with sort of emphasis on biases. So it was like a 5-mark question, so you didn't have to sit there and write for 10 marks. It wasn't a full appraisal, but you just needed to mention key biases and sort of your understanding of where to look for mistakes, or if you can see any mistakes in that study design, and try to critically appraise it. I think qualitative one was probably the hardest one, but it didn't seem like a hard question. I think a lot of the people did a really good job with it, because I think there were like little mistakes in it that were quite obvious. But the reason why I'm sort of spending so much time in critical appraisals for this particular presentation is that I'm hoping that you can use it for next year. So next year's third year for you guys, and you will have to critically appraise an article. So this year they gave us 6 articles to critically appraise in our own time. And the plan was that we'd go and regurgitate one of them at an exam. But because of COVID, now it's an assessment. So it'll be a brand new article that we'll have to critically appraise like over the period of 24 hours at home. And yeah, just in order to do that, you kind of need a template to go by to critically appraise something. So this is what I'm doing now. Again, I'm giving you a few tips about how to go about it. So for instance, for third year, they provide you checklists for that study design. I personally find them semi-useful. So it's good to sort of go and take, oh yeah, they do mention this in the methods. Oh yes, there is randomization. Oh yes, there is blinding. But it's quite superficial, because a lot of the nitty-gritty details come from reading the article and knowing what DHC wants you to comment on. So these checklists can sometimes miss that. So what I did last year is that you would get answers for every critical appraisal that's asked of you in PBL. It's usually released after the PBL is finished, and there'll be, I think in the last trigger, there'll be just a cut and pasted text of how somebody in the school appraised that article. So use that text and sort of distilled sort of what they wanted us to mention, sort of reverse engineered that critical appraisal answer. And that really helps. So I've appraised 3 articles out of the 6 for DHC for third year, and that structure really helps, and it's more helpful than the checklist that they provide. And I think what particularly helps is using their lingo. So using the certain phrases and the words that they want us to mention. So definitely mention biases, definitely mention representative sample if that's what the study wants you to talk about. So internal and external validity, mention it. But in order to do that, you need to understand study design and PICO as well. So that's why these critical appraisals are so complex. Okay, so again, up to you if you want to sit through this, turn it off, come back to it later in third year. But yeah, I'm going to sort of dive into the 3 or 4 of them now. So next slide is critical appraisal checklist. So just to give you an example, this is more useful for third year. So recently I did an RCT appraisal and sort of sat there ticking yes or no for certain things. And RCTs are really hard to evaluate because they are so structured and they are so by the book. So I actually found it really difficult to critique that study, because a lot of it was done quite well. So in that case, the checklist kind of helped, but for most other study designs, the checklist is horrible and ugly looking and doesn't make any sense, and then it doesn't actually tell you how to critically appraise anything. So anyway, but I'll just give you an example. Okay, next slide is critical appraisal of generic template. Okay, so always sort of, if you don't know what to do first, to do a PICO, just figure out what the population is, what the intervention is, what the control is, and what the outcome is. And then the next thing is for you to look at the internal validity. And that kind of starts with the recruitment process. With any study that you're looking at, you need to look at how well they've recruited people. The one thing you can comment on is possibly, was it random? sampling, or was it consecutive? Did they even talk about sampling? How did they sample people? A lot of articles skip that step and they don't describe it, especially in medical literature. So that's something you can comment on already. They didn't talk about how they sampled. That could create selection bias. Were they picking people because they looked healthy? Were they picking people because they looked more sick? Which already is in itself as a selection bias. Selection bias can include presence of confounding factors, which is more kind of relevant to cohort studies, and loss to follow-up is a great one. So if the study wants to recruit as many people as possible, let's say they recruited 500, but 200 dropped out, that doesn't look good. It's more of a selection bias, because what if those 200 were more sick, in which case you're looking at more healthy population of people to study, which is going to overinflate your results. Like, they're going to respond better to treatment, they're going to be more motivated. So again, if you can mention the bolded things that I'm about to talk about, selection bias, measurement bias, sample size, that's like the majority of your marks from the critical appraisal. Next one is measurement bias. That's also quite an easy one to talk about, because it will come up in methods and sometimes in results. But essentially, that's the paper talking about how they measured things. Did they use people's memories to comment on things? Sorry, excuse me. For instance, a lot of interviews, dietitian interviews, for instance, can occur. Oh, what did you have for breakfast yesterday? That's recall bias. I sometimes can't remember what I had for breakfast yesterday. Observer and interviewer bias are kind of similar, and it basically means the person who's interviewing you, if they're the only person interviewing you, and there is no recording of that conversation that an independent person can then score, then you can, as an interviewer who is the only person doing the interview or the assessment or the questionnaire, you can influence the study results by asking questions in a leading manner, less objective ways, inserting a bit of emotion and just basically meddling with the protocol. So it is always best to have at least two independent interviewers, or at least one interviewer and then an independent person who then scores that interview. So again, that has done often, and you want to look for people for words like independent or score, and then an independent or second scorer scored the interview. Again, using poorly validated tools is probably the goal, what you're looking for when you're looking for measurement bias. So, for instance, if I make up my own depression scale without like collating it and going through the whole validation process, that's measurement bias in itself, because there are many validated instruments that can measure depression out there. Why am I using my own? Other things that you might want to comment on is quality of the stats analysis, which is hard to do if you haven't done stats. I actually honestly rarely comment on that because I feel a little bit out of depth, because stats analyses can be justified depending on the data that's being analyzed. The one thing that I can comment on is that it is a pet hate of mine when people use parametric statistics for scored questionnaires. Basically, parametric statistics is using questionnaires as a continuous variable, but intrinsically they're not. It's a scale of 1 to 5, 1 being, the worst day of my life, and 5 being the best. So that's one thing that you may want to comment on, is that they're using statistics that are meant to be for continuous variables when it is actually a scored questionnaire. One way to get around that is using rash analysis and questionnaires, but again, rarely that's done. So it's a very niche thing. So if you know what I'm talking about, great. If not, forget about it. Funding is important, especially for RCTs. So if an RCT has been funded by a big pharmaceutical company, I personally wouldn't trust that study, because there is a lot of spin and bias when it comes to being funded by a pharmaceutical company. Undersampling is a huge one. So basically, if your study has 30 people in it and you didn't get your p-value, your significant value, it's quite likely that your study was underpowered, or in other words, used a too small of a sample size. So, but at the same time, if you have a ginormous study of, let's say, 300,000 people, and you found a significant result, well, if you throw that many people at anything, you'll find a significant result. So it's kind of, yeah, there are two extremes, not too little, not too much. And then study-specific sort of generic templates. So you would use Rambo for RCTs that you learned last year. For prognostic studies, they have their own special biases that we're going to talk about later, and diagnostic studies have their own biases as well. For external validity, what you do is you basically look at all the biases that you've identified in internal validity, and you say, if there are too many biases, I don't think this is a soundly designed study, and that the results are unlikely to be generalizable to the population that they were originally studying. And in RCT specifically, there is a volunteer bias. Healthy volunteers volunteer for RCTs in general. So that's always a bias that you can mention in RCTs. Again, we talked about sample size. Basically, yeah, comment if it's not a significant result, then you can talk about the sample size. And then just in summary, I guess, summarize what you've already talked about. All right, prognostic studies is the next slide. So I've decided to cut and paste sort of biases that were taught in first year about prognostic studies, sort of as a refresher for what they're looking for you to mention in the critical appraisal. So again, I've already talked about selection bias. It's when you select the patients for the study. So for prognostic studies, the three things that they want you to look at for selection bias is a non-representative sample, lag or lead time bias, and attrition. So again, let's recall again, the prognostic study is where you recruit people with a particular exposure, and then you track them over time to see if they develop an outcome. So again, your stereotypical study that's done to death would be people who are smokers, so smoking being the exposure, and you're tracking them over time to see if they develop lung cancer or whatever other disease that is a risk factor from smoking, which is essentially everything. So if you're doing that study, if you use sampling from a tertiary respiratory center, those patients are going to be too sick. So they're because they're referred already to that tertiary center because there is something wrong with them. That's a non-representative sample. You're sampling people who are too sick. Ideally, you want to sample in the community, primary healthcare. So a person coming in who smokes, you want to recruit them for that study as a GP. Again, really difficult to do in real life, hence why these things happen and the tertiary center starts recruiting for things like that, but it's a massive selection bias. Lag or lead time bias. Okay, that's really important. So if you want to observe people develop a disease over time, you need to be really careful that you're not selecting people who are too late or too early in their diagnosis. So what I mean is that let's say we're doing that smoking study, if you're selecting people who have just started smoking, let's say they've been smoking for a year and they're quite young, that's too early in their diagnoses. They may actually quit throughout the study. So, and let's say you're tracking them for the next 10 to 20 years. They might quit, or their lungs are too healthy to develop anything in the next 20 years because it takes quite a long time to develop lung cancer. So that's an exception of lead time bias. You're too early. And then lag time bias is that you've recruited a 60-year-old lady who's been smoking for the past 40 years. Again, she's already probably got lung cancer. You don't even need to wait for her to develop lung cancer. So again, that's too late. So it's lag time bias. Attrition, loss to follow-up is basically, again, something you can mention all the time. Loss to follow-up is notorious, especially in prognostic studies. So in my research, I think my loss to follow-up was, 50, 60%. It was crazy. And yet that's quite normal, especially if the patient population is quite sick and elderly. That that's quite expected. So it's hard to then analyze that data because it's already quite biased. So yeah, I think anything over 20%, I think is considered. I think over 20% in RCTs is considered bad, but I don't know about prognostics. It might be a bit more generous, maybe over 30%. Definitely nothing over 40%. But yes, again, like I've said before, if those people who are dropping out are sicker, then you are left with a healthier population that is going to make your results look better. Okay. Measurement bias. Again, I've briefly talked about it, but let's talk about it specifically about prognostic studies. So unmeasured confounders. So I've always struggled with that because if they're unmeasured, how do you know which ones are the confounders? And that's something that you need to be a little bit more clever about. So, I mean, the most obvious one is not accounting for age and gender, which essentially every study that's in medicine does account for, because these are the most sort of important confounders to account for. But sometimes they don't, and that's important too. Like even lower CS, that's an important confounder, because lower CS people are going to be less healthy, less medically literate. And accounting for past history of disease. So if you're recruiting people into the lung cancer study who have lung cancer in the family as a history, then again, that's an unmeasured confounder that you didn't consider. So basically, when you're reading the prognostic study, you need to think about like what else could affect these results? What else is there that you would look at, but the study didn't look at? Again, that's probably the most hard one to analyze and figure out. So hopefully you can sort of anchor on the subjective and the other two biases that I'm about to talk about. So subjective reporting. Again, that's an easy one because it's usually means only subjective outcomes are being measured. And what do I mean by subjective? So anything that requires self-report by the patient. So something that you didn't measure yourself. If you measure it yourself, preferably something biological, that's an objective measure. If it is a diary, a questionnaire that the person wrote down, or an interview with the person where they're speaking about their experience, that's a subjective measure because, again, subject to recall bias, subject to distortion, people's memories are generally quite horrible. So if you want to talk about subjective reporting as a bias, you're basically saying there are too many subjective measures and not enough objective measures. Some of the objective measures that you might want to look at is, for instance, if you're measuring stress levels in medical students, a subjective measure could be an anxiety questionnaire. An objective measure could be cortisol levels from saliva. So something that you can quantify. Yeah, basically an objective measure is a quantifiable measure. In psychiatry, I guess that would be quite different because a subjective measure would be a questionnaire, a self-report questionnaire that a person filled out, let's say an anxiety questionnaire, but an objective measure would be, I guess, a more of a standardized questionnaire conducted by the psychiatrist or a clinical evaluation conducted by the psychiatrist. Again, psychiatry is quite a subjective science in itself, but that's as objective as it can get in psychiatry, although they can certainly also measure cortisol levels. I'm just thinking in terms of coming back to the lung cancer study, subjective measures could be the patient's estimate of PAC years. So that kind of estimates the severity of their disease. And an objective measure could be doing something like a chest X-ray or a CT to actually look at the changes in their lungs and correlate their lungs to what they're saying. I'm sure there are others, but I'm just making stuff up on the go. An ascertainment bias, it's, again, I haven't actually come across that myself, but I guess it happens. It's basically not all patients are followed up for the same amount of time. And I'm guessing they're looking at control versus intervention. So let's say controls are followed up for 10 years rather than 20. And the group of interest, the lung cancer group, is followed up for 20 years, in which case it completely distorts your results. All right, next slide, prognostic studies, template number 2. So this is the distilled version of the reverse engineering that I did on the example that was given in second year. And again, it's essentially what I've talked about in the previous slide, but sort of a little bit more streamlined. So what they first wanted you to talk about is the sample representative? And you look at the biases from the slide before. Was the follow-up sufficiently long? I think that's also an important question to ask. So for lung cancer, your follow-up has to be at least 20 to 30 years because it takes that long to develop. For something like influenza, you probably might want to look at just a year because the seasonal flu season happens every year. And again, for something like stress levels, cortisol levels in med students, you might want to look at it continuously for the next 6 months or even a few weeks. You're still going to get results. Outcome criteria assessment. So again, we're looking at subjective versus objective measurements. And is it blinded? So, sorry, I'm going to have to say this. But blinding is something that is... Blinding and masking is the same thing. Blinding is a word used more often in Australia. Masking is a word that's used more often in North America and maybe Europe. So just remember that those are the two things. Blinding is essentially... For prognostic studies, I'm just thinking, how would that work? It's not an RCT. Blinding, sorry, I had to pause and then start again. I just looked it up. Blinding is difficult in cohort studies, so I might remove that from the slides. I think the most important thing with prognostic studies is that it's done as objectively as possible without bias. So I guess when they say blinding, they mean if there is interviewing happening or any assessment happening, it has to be validated by an independent reviewer. So that's kind of blinding of the assessments is what's important. It needs to be done as objectively as possible. Again, we talked about adjustment for prognostic factors, such as like past history, age, gender. And then obviously, if we're talking about a survival, is an appropriate analysis used, so like Kaplan-Meier curve. Precision, again, precision is essentially sample size. So, and the higher the samples, the higher the number for the sample size, the better your precision. With that particular study that kept going on about confidence intervals, I don't see them as often as DHC would like to see them in literature, so I don't think it's that important. But you may as well mention it in your analysis if you like. And then obviously you extrapolate from everything you've talked about internal validity and you say, would I trust the study? Is it generalizable to the population at hand? All right, next slide is diagnostic study, critical appraisal template 1. So again, first off, let's talk about the biases that you're expected to know, and then we'll talk about the flow. So spectrum bias is a type of, I guess, selection bias. So that has to do with recruitment. So imagine, let me come up with an example as we did with the lung cancer. Okay, let's stick with my cortisol example with medical students. So let's say cortisol in saliva is the new diagnostic test to test for anxiety levels in medical students, and the gold standard is like a psychological evaluation with anxiety questionnaires. So if you take that design to, let's say, Harvard, for instance, and compare it to the Gold Coast, I think the stress levels at Harvard might be a little bit higher than on the Gold Coast, which means your mix of population is different. You're comparing a high stress environment where cortisol levels will be higher versus a relatively low stress environment in the Gold Coast. So again, these groups of patients are not comparable. Probably a better example would be, let's say you're trying to diagnose cholecystitis in different hospitals. And one of the hospitals is a tertiary center for GAT disease. So that's an example of spectrum bias because one of your centers with the tertiary center will have higher prevalence of cholecystitis because it's a tertiary center for GAT problems. Okay, verification bias is a form of measurement bias. And essentially, I think the following three biases are what happens when you're, okay, so maybe just go back to the basics. When you design a diagnostic test, you always compare it to a gold standard. You know, that 2x2 grid where you need to calculate sensitivity and specificity. So in order to design a diagnostic test, you need to always cross-reference and cross-check all of your results to the gold standard. In verification bias, you're only sending off either positive or negative results of your diagnostic test to cross-check with the gold standard. In a perfect world, and ideally, you need to check everyone, positives and negatives, against the gold standard. But a lot of the times it's either not feasible or too expensive, so people get away with either a positive or a negative result. And that results in overinflation of the sensitivity and specificity, depending on which one you're looking at. Treatment paradox does the same thing. It overinflates the values. And essentially it's when you treat before the gold standard is applied, which means you're going to get sicker people and the gold standard is going to pick it up. So again, it's overinflating your result. Again, it will become more evident once you read the study and you realize that they're treating before they're doing the gold standard, and straight away you can just say it's a treatment paradox. Disease progression bias is in the word when there is a time delay between your diagnostic test and your gold standard. And again, by the time the gold standard is applied, the disease is more advanced and therefore it's more likely to pick up what you're trying to test, and therefore that will again inflate your sensitivity and or specificity depending on what you're looking at. Incorporation bias is again another type of measurement bias. I should have probably grouped them the other way around. And it's when your index test or your diagnostic test that you're testing kind of is either completely the same as the gold standard or includes part of the gold standard. By the way, index test is the diagnostic test, reference standard is the gold standard. They're interchangeable definitions. And actually that happened in the diagnostic test that we're looking at for DHC at the moment. Essentially, they looked at ultrasound detection of cholecystitis in the ED versus ultrasound detection of cholecystitis in the radiology department. And their claim is that the diagnostic test is the ultrasound in the ED and the gold standard test is the ultrasound in the radiology department, but it's the same tests. There is no gold standard. The only difference is the qualification of the people who are administering the test. So that's a beautiful example of incorporation bias. The two tests should be completely different and independent of each other. Again, these are probably the most tricky ones to get your head around because I never came across them before studying med. And again, they're not taught really well, but there is a website at the end of the presentation called catalogofbias.org, and it explains most of the diagnostic biases really well, and it tells you sort of the outcome of that bias, like what does it inflate and why. So if you're interested and you need more information, because I'm not sure if I did a good job, so have a look at that. So next slide is, again, just wanted to give you a diagnostic test refresher. So at the top, we've got the gold standard, and that's, you know, your colonoscopy in the fecal occult blood test, or I don't know what the gold standard is. Colposcopy, I guess, for the cervical cancer. Yeah, a biopsy. So basically, gold standard is your reference test, and then the test outcome is your index test or the diagnostic test in question. So let's say your HPV test. And that's how you calculate specificity and sensitivity. One thing about this is that remember that positive predictive value and negative predictive value are dependent on prevalence, whereas specificity and sensitivity, as well as every other outcome like the LRs, they're not. So what that means is if you're sampling from a population with a high prevalence of that disease, let's say that tertiary center with the GAT problems, and you're looking at cholecystitis, that's going to overinflate your positive predictive value because the prevalence there of the cholecystitis is higher. So that's another thing that you might want to comment on, and that kind of shows DHC people that you understand sort of core basics of diagnostic tests and their values. All right, next slide would be the template number 2. And essentially, again, that's the same stuff reverse engineered from before. Internal validity, you want to talk about a representative sample yet again. You're looking how people were recruited. Was it done randomly? Was it random sampling? Were the cases mild? Were they advanced? Essentially commenting on spectrum bias. You want to make a comment about the reference standard. Is there one? I.e. in the case that I talked about with emergency department and ultrasound, there wasn't one. Is it objective? That's also an important one, because a lot of the times, especially in psychiatry, the reference standard is like a clinical exam or a consultation with a psychiatrist. And although it is as objective as it can be in psychiatry, you can argue that it's not ideal. Did the reference standard vary between patients, which apparently happens? So again, that leads to verification bias and treatment paradox. The comparator group. So remember when we talked about PICO for diagnostic studies? Your reference standard, either or, it's either an intervention or a comparator. So the comparator group, is it blinded? What is the length between the test and the gold standard? Was their clinical judgment used? So this is where you talk about disease progression bias and an incorporation bias. I'm pretty sure comparator group is the reference standard group. I don't know why it's split up like that. Because the intervention is your diagnostic test, although you can argue either way. External validity is essentially the summary of the internal validity and whether you will trust the study or not. Results, again, you need to comment on the specificity and the sensitivity that's been reported. Are they high? Are they low? And why? Because essentially, if there are lots of biases in the study, you can't trust the specificity and sensitivity, and you need to comment on that. Again, comment on the small sample size and any discrepancies that you see. And then, did they calculate their positive predictive and negative predictive value, comment on prevalence, and the likelihood ratios as well. And yeah, is it applicable? Is there enough information to replicate the results? Okay, next is treatment study, or otherwise known as an RCT. And template number 1, and again, is biases from year 1 or lows. Like with the prognostics, it's nice and neat. So selection bias, you're looking at volunteer bias, loss to follow-up, and allocation bias. So volunteer bias is probably the easiest one. It will always apply to RCTs. People who volunteer for RCTs tend to be more homogeneous and healthier, and that's an external validity bias. It's external validity affected already, so that's a given. You can always say that. Loss to follow-up. So recently I found out that 20% is the allowable loss to follow-up in RCTs, so 80% participation. And again, anything lower than that, lower than 80% or greater than 20% loss to follow-up can overestimate the treatment effect, especially if you don't use intention to treat analysis. And allocation bias is basically, was randomization properly done? Was it blinded and or masked? So usually with randomization, you want a computer-generated sort of randomization computer-generated randomization can never be purely random, but you try to be as random as possible. The study that I read recently talked about how they just shuffled down envelopes. I guess that's good enough as, randomizing, but sometimes with shuffling, if you don't do it properly, you can get 5 people in a row who get treatment and then only 1 person who gets the placebo. So you can comment on that always. Measurement bias, again, detection bias. I haven't seen that much, but I'm sure it happens. It's just differences in outcomes between groups. So you're measuring outcomes in the control group and the intervention group quite differently. The gold standard, and you should always measure the outcomes the same for both groups. So if that doesn't happen, instantly it's detection bias. Again, performance bias is similar to detection bias, but suitable exposure. So the 2 groups are not exposed to the same things. Technically, intervention and control and RCTs should be treated exactly the same. The only difference is that, I'm using placebo as an example, but there could be other ways to do RCTs, such as intervention versus like an interventional drug versus a standard drug. But I'm just talking for ease, placebo. So the placebo group and the intervention group, everything's the same, but they think that some of them think they've got the intervention, some of them think that they have the placebo. They don't know. Everything should be the same. If there are differences in exposure, that's something to comment on. Blinding, again, we talked about it a lot. Appropriate masking and intervention control. What you need to bear in mind for RCTs is that the patients don't know that they're getting interventional control, and the doctors or whoever's administering the procedure, the drug, also doesn't know that they're administering either a placebo or a control, and that's a double-blinded randomized control trial, and anything less than that introduces bias. And obviously, again, we're talking about scoring independently, that not one person is observing everything. A second person should be double-checking everything that they're doing. And selective reporting is probably the most fun because most RCTs are published with positive results or some sort of significant result. So again, you can always comment on that. Like, hardly ever is there an RCT that publishes a negative result, although it's happening more and more often. A good way to test that is that most RCTs are registered on clinicaltrials.gov. So when you do read an RCT for a critical appraisal, look at their registration, because that registration happens before the study is actually carried out. And look at their primary, secondary, and other outcomes and what they plan to do with the data. And if their primary outcomes and secondary outcomes or anything differs from the paper that they're writing, that means that some meddling has happened. They've decided that they didn't get positive results and they reanalyzed or did something different with the data that they initially intended. And that already is in itself bias and also selective reporting. Another important point to comment is subgroup analysis and RCTs. Again, essentially, if that clinicaltrials.gov protocol doesn't say that they intend to specifically look at a particular subgroup because they're interested in it from the beginning, and then they do, and let's say they don't mention that subgroup analysis in the original registration, and if they all of a sudden do subgroup analysis in their paper, that makes you think that they're fishing for positive results. Usually, if the subgroup analyses are not pre-specified earlier on, that means they're looking for positive results. All right, next slide is treatment study, clinical appraisal template 2. Again, Leonard, I think, talked to you about Rambo last year. I find it a bit difficult to use because basically it's a recruitment allocation and then everything else. So again, we talked about recruitment, we talked about how groups should be comparable from the beginning. Another thing to look out for ICTs is too tight of a selection criteria. So there is always inclusion and exclusion criteria for ICTs, but if you make it too tight, you're kind of biasing results towards a positive outcome because you're excluding too much variation. And there has to be an amount of variation in RCT trials so they can be applicable to the general population. Again, how was randomization done? Was it shuffling of paper envelopes or was it computer generated? Did they use a central location? If there are multiple locations, there is more opportunity for things to go wrong, and look at any prognostic factors, just like with the cohorts. Allocations, are groups treated equally? Is there an allocation bias? We talked about it before. And then look at 2Ms and a BO, so maintenance, measurement, blinding, objective. So is treatment blinded? Are clinicians blinded? Are they using objective tools? Is loss to follow-up less than 80%? Sorry, loss to follow-up should be less than 20%. I should correct that. With the results, it's not always applicable to all of RCTs, but that DHC drives that point home so hard. So intention to treat is the least biased analyses. And if it's mentioned in the results or methods, that's great, but sometimes it's not, and you just don't know what analyses they've used. And last observation carried forward is when they use Again, it's more common in trials where there is big loss to follow-up. And then when they look at the dropouts and treat them the same as loss to follow-up patients, basically it just means that the dropouts or people who are lost to follow-up are sicker, and that means that the patient that you're looking at and the one that's remaining with you is healthier. So again, it's quite a biased way to analyze data, and therefore will give you better results. Again, are there reported outcomes ratios or p-values or confidence intervals? I think an important thing that I think Lambert wants you to comment on is, are the results clinically meaningful? And I think that should be written in the article. And I think it's a powerful thing to also, when you analyze the RCT and they say, oh, we found a significant result of like 0.1% in between these two groups, and that's all well and good, but if that significant result doesn't make any difference for the patients in the trial, then it's not clinically meaningful, and therefore you can be happy about your drug working, but the people won't tell the difference, and they'll probably never be compliant with it. So I think it's called p-hacking, and basically just because you've got a significant p-value doesn't necessarily mean that it does anything, because p-values can be manipulated, and it's really easy to get a good one if you know how to design it well. But I think clinical meaningfulness has become more of a measure of ICT quality. And also you want to talk about adverse effects. So I don't know if you've ever heard an American pharmaceutical ad, and it says something like, there's a beautiful ad of a person on this particular drug and, you know, their life is great. But then there's this voice at the end saying, adverse effects may include sudden death, anal leakage, and like impotence. And you're like, what? How did this happen? So yeah, just pay attention to adverse effects. If they're too adverse, you might want to comment on that. Again, mention type 1 error and type 2 error as well. I think you can mention that in basically any study. Type 1 error is more applicable to ICTs when they've done multiple comparisons, and which include subgroup analyses. And if they don't adjust for those comparisons, that inflates your p-value. But usually that's kind of detected at the review stage. And then type 2 error is your usual undersampling. So if the sample size was too small and they didn't find anything, you can comment on that. And then you summarize the results and talk about external validity. All right, cohort studies. I think we talked about them before, but we talked about them in terms of prognostic studies. Prognostic studies usually are either cohort studies or RCTs, but specifically cohort studies. They're probably one of the least structured appraisals. Again, you will start with the PICO, and then you can sort of talk about, like, is this an appropriate study to study with a cohort design? And then you look at internal validity. Again, you're looking at recruitment. I think it's becoming quite repetitive, but hopefully it drives the point home. You're looking at representation, inclusion criteria and exclusion criteria. Is it too restrictive or is it too liberal? You're looking at participation rates, such as, you know, loss to follow-up, and anything that can create selection bias, which is what we've just talked about. Again, remember, cohort studies, you start with the exposure and you look at the outcomes. So you look at subjective and objective measures, and you want to comment on their balance and whether there are too many subjective measures. Are they using valid instruments? Is it the same exposure for everyone? Remember the smoking lady, one who's 20 and smoked for a year and one who's 16 and smoked for 40 years. Is there much missing data which can create selection and measurement bias? And how is the data collected? Is it objective, subjective? Is it done properly in a particular structured way, or is it just willy-nilly, decided to write everything up in? Outcome measurements, again, we're looking at recall bias, observer bias, interviewer bias, and again, it's the same stuff I've talked about before. 2 independent researchers is better than 1. Inter-observer reliability comes up a lot, and it's basically, let's say, let's say I'm looking at videos of interviews, And let's say me and my friend are the independent researchers who are independently looking at those videos and scoring them. Perhaps we have an independent questionnaire that we need to score. So what you could do in a good study is look at our scores, me and my friend, and look at the inter-rater observer reliability. So our scores are similar. So basically, do we agree in how we score the data? And that kind of shows that if we do similarly to each other, and let's say there is an agreement between our scores of 80%, that means that we trained the same way and we're consistently scoring it in accordance to protocol. Obviously, we could both have internal biases that could agree, but it's less likely than just a good training and being more independent. And then you want to look at confounding. And again, we talked about unmeasured confounders. One thing that's really good about cohort studies is using multivariate modeling. And it's basically you are loading all of your variables into a model and you're trying to make sure as many of them are accounted for. That's as much as I can say because I don't really understand I kind of understand the statistics, but I can't explain it here. If you're interested, you can look that up. But I guess the key is if they don't mention it in the paper, you could suggest that as a potential improvement to their analyses. And you can talk about effect modification, but a lot of these biases, and including effect modification, I'll talk about in the first year lecture that hopefully I'll do in a couple of weeks. And again, you want to look up follow-up. Is it sufficiently long? Is sample size and power appropriate? And you can mention type 1 and type 2. I kind of realized that I've just explained to you cohort studies twice, one in relation to prognostic studies and one in relation to cohort studies, but essentially they're the same. So don't worry if it's confusing. I apologize, but hopefully it makes sense. Okay, next slide is review Q&As on. So that's basically the end of the lecture. Thank gosh. I'm so sorry. I've been talking for over an hour. So some of the things that I think that are in your LOs are work cover. As far as I remember, it's only come up in MCQs. I don't remember an SAQ question on that. I remember a lot of Q&As on home care packages program versus Commonwealth Home Support Program. I don't remember that ever coming up in SAQs. Maybe there was one MCQ question, but again, I'm thinking these are on the low yield side, including transition care, respite. I think there was an MCQ on ACAD, but it was pretty self-explanatory. Osteoporosis, I think it's like, there's one, I think, DHC question about it. I think it's more likely to be a DKHI question. Risk of falls is important, and I think it's important for clinical years as well for your aged care rotation. So that's probably something you might want to focus on, and vision and hearing aids as well. I can't remember the drug and alcohol stuff coming up for the LOs. All right, next slide. Quick note on the DHC project. So I think you've got a DHC project coming up in July, August, and you've already would have done a PICO or about to do a PICO. The thing with coming up with your PICO is that you can change it. So if you come up with one right now and you absolutely hate it, you can change it down the line, which I think a lot of people end up doing. Personally, for me, it was really hard to take the DHC project seriously, having written research grants and written papers before. I can see why they're doing it. It's just, what else? Like, I think everyone hates that project to an extent, so I'm no different. So I think with the DHC project, I think you just need to have a strategy, because it's really easy to get sidetracked and get lost in where to start. So the way that my group did it is that we found a paper that we really liked, and it was only done in the States, and we decided to replicate it in Australia. And there is nothing wrong with replicating a study, because replication in science makes better results. So you could do that, but at the same time, I've had other friends who did excellent projects and were really creative. So they were like, let's think of an intervention and an outcome that we want to study. And I think they ended up studying something like effective modafinil and Alzheimer's. So you can just take like a completely random drug and then apply it to a disease that it's never been studied in. And that's your DHC project in a nutshell. A lot of people use, So you will naturally have people who have never done research and people who have done research in the DHC group. And some people who have done research will kind of want to do their research project, but in a modified form. And if your group is all right with that, and if that's what you want to do, then go and do that. I know some of them can be quite niche and quite difficult. And I definitely didn't want to do anything because I think you only get $50,000. So you can't really do a big lab project because lab equipment costs money. Like I think it costs something like $3,000 a day to even run a lab for one day. So yeah, I wanted to rule out wet lab research straight away. But again, if you can make it work, just discuss it in your own groups. But I think seeking feedback from your DHC project people who have done research before is a good idea because I think there is a discrepancy between some people who have never done research before and they think they know how research should be done, but in reality it's never done that way. So it's good to sort of double check, does it actually happen in research? And people can say no, it's just, it's the gold standard, but it's actually never done or something like that. Questionnaire research is easy, it's not as flawed as everyone thinks. So you can just do anxiety questionnaires in med students, and as long as you can if you all like it and that's what you want to do, then go for it. I think last year someone did a research project on Lime scooters and they passed. So yeah, try to do something fun or something you're interested in. Don't do a rural artsy project that you think would please DHC, because surprisingly, a lot of them are experts in those things and they're going to be more harsh on your research design. So you think it might be something that DHC would like, but it might actually be harder to do than you think. And also, knowledge of study designs helps here too. So don't do an RCT unless it's a mini pilot, because RCTs are hugely expensive. A cross-sectional study such as anxiety questionnaires and menstruals is easy to do and easy to write about. And it's an understudied area, so it's always easy to do that. Or you could do something about COVID right now. So anxiety levels in COVID. There you go. A prospective longitudinal study will require more resources, but if it's a short one that is runs over a couple of months, then it's fine. I think chart reviews and I think reading of medical records and doing medical record research might be not allowed. It wasn't allowed for us last year. All right, that is the last slide. Good resources slides. Basically, if you're keen and if you're interested, these are the 3 really good websites that can answer some of your biases, clinical appraisal questions. And last slide, good luck everyone, and may the odds ratio be ever in your favor. I hopefully will finish the first year lecture in a couple of weeks' time and you will have access to it to revise before the exams. But obviously BMB is anatomy heavy, so good luck everyone. Thanks.